Now we move on to our seventh session, which is a very interesting one. It is hematological cancers of the young. This session will be chaired by Dr. M.B. Agarwal sir, Professor and Head of Department of Hematology at the Bombay Hospital Institute of Medical Sciences. He is also the honorary hematologist at Lilavati Hospital, Breach Candy Hospital, and president of the Mumbai Hematology Group, and one of the most respected teachers in the field of hematology in our country.
Good afternoon to everybody. I thank Professor Prakash Chitalkar for this opportunity to chair this session. The first speaker is Dr. Sharath Damodar. He is Senior Consultant Hematologist and Head, Department of Hematology and Bone Marrow Transplant Unit at Majumdar Shah Medical Center, Narayan Health City, Bangalore, and he's going to speak to us on INOTUZUMAB, paradigm shift in treatment of young adults for relapsed refractory CD22 positive B-cell acute lymphoblastic leukemia. Sharath.
Thank you, sir. I'd like to start by thanking Professor Chitalkar again for this opportunity to actually make this little presentation. We have a mixed audience, so I'll try and keep my talk as less technical as we can be and keep it more generalized for people to understand. Yeah. So when I was a medical student about 30 years ago, the diagnosis of acute leukemia itself used to be a death sentence, but things have progressed from there. And now you've got cure rates with initial treatment itself, which could be chemotherapy, especially in the lymphatic leukemias, and in the myeloid, it could be chemo plus minus a transplant. And transplant is kind of available in most parts of the country now with a curative intent treatment. However, if you have a relapse of leukemia, that in a sense is kind of more or less a death sentence for most people. But clearly with newer treatments being available, immunotherapy, antibodies coming up, I think we're finding ways to even tackle that. But I will just put things into perspective, including one of the molecules which I will discuss over the next 15-20 minutes. So I will start with a real case which actually we treated. A 42-year-old lady diagnosed as acute lymphatic leukemia in January 2020, also diabetic hypertensive. Cytogenetics had hyperploidy. She was negative for all the other markers. She was treated with an intensive chemotherapy, and after 4 cycles, she went into a morphological remission. In today's day and age, people detect something called minimal residual disease, and she was just borderline on that and went on to maintenance chemotherapy after that, which is what is done for most of the initial treatments of leukemia, ALL. However, in December 2020, she relapsed with a marrow showing about 66% blasts. And at that point in time, she also received some more chemotherapy, which is usually what is done. But clearly, we need to move away from that because it's got a lot of toxicity and issues. And we also want to see whether there are any better treatments available. That's the whole idea of doing this little session. So the bone marrow was full of these cancerous cells. And nowadays, in today's day and age, flow cytometry is routinely done in all the leukemias to make diagnosis and even at relapse. And the idea is to try and pick up some of these markers which are expressed to see whether they can be targets for treatment. So you can see that the CD19, the CD20, CD22 are in the 99% range here. And we've got some targeted therapies for that. So this patient received one of the drugs, which is INOTUZUMAB, which is an anti-CD22 antibody. She got the first cycle at the particular dose, and then subsequently she still had blast, which had come down. Got a second cycle, after which she became complete remission or MRD negative, and subsequently underwent a bone marrow transplant with a match-related donor who was incidentally her son. They are from a very close community with a lot of common HLA haplotypes, and thereby the son was actually fully matched. It's a rare thing, it can happen. Underwent chemotherapy and then subsequently had a transplant, and about 3-4 months down the line, she's well after adequate engraftment and is discharged. So this is one of the good stories when you have a relapsed leukemia where you've given some form of salvage therapy and subsequently undertaken a bone marrow transplant and tried to cure the patient. So this is the last status on follow. Now we'll come to reality. Now, relapsed acute lymphatic leukemia in the adult or the adolescents has a pretty dismal prognosis. You can see data from the West, published data. You can see the survival curves here are in the 5 to 10% range across the board, across various age groups. And thereby, with these dismal outcomes, we need to find mechanisms to kind of salvage these patients. Now, when they have some kind of salvage treatment, and then you look at their ability to develop a remission, that is, they go into a complete morphological remission or even minimal MRD negative, then if they achieve that, then they plateau at about 40% where they've got some response rates. Whereas if you don't respond, then it's a dismal outcome. And post that, it's just not enough to get a response. You need to undergo HSCT or a hematopoietic stem cell transplant. And only with that will you get about a 30 or 35% survival for about 6 to 7 years down the line. Other than that, most of them would not be able to survive. So once the curve is plateauing there, you can see that it kind of plateaus in the 30-40% range. But that's the best you can do. So clearly, there's a path to follow when you have somebody with a relapsed leukemia. Now, what about data which is there in first relapse, second relapse? If you look at it from an age-specific group, obviously the younger patients do better. You've got response rates of about 30 to 40% of patients who can achieve a remission even after relapse with various chemotherapies. This is data from various US centers. However, this is a nice little article on the myth of second remission of acute leukemia in the adult. And they found that when they actually went back retrospectively and analyzed all the subset of patients who had relapsed, a lot of them don't even get to a second salvage treatment. And thereby, if you put all those together, the outcomes are not very great. And you can see the curve plateauing here in the 10% range of survival. And you can see that it goes up to about 20-odd% when you have a matched sibling donor available. And if it's an unrelated donor, or nowadays in today's day and world where we do half match or haplotransplant, they are a little lesser than a sibling transplant, which achieves about a 25% long-term cure. And in cancers, generally, whenever we say long-term cure, we're talking beyond 5 years. So if you've kind of gone beyond 5 years, then you start talking about cure rates. So clearly, the picture clearly tells us that we need some kind of salvage chemotherapy, and it has to be topped up by a transplant. What about Indian data? This is an article put together by Radhakrishnan and et al., where they've looked at multiple institutions, collated all this data, and they've looked at proportion of patients diagnosed in various centers, their ability to undergo chemotherapy, the remission rates across the board, and relapse rates, which have varied from anywhere between 25 to about 60% at various time points. So this is actual data from our country. And when you look at what happens to people who relapse, you would realize that most of them opted for palliative therapy. And these range from 70 to 90% in various studies. So clearly there is an issue of financial toxicity, access to treatment, getting, the family support. So many issues are there when you have a relapse of disease, and thereby this is not easy to treat. And certainly we have to factor in all these issues when we talk about treatments to salvage. So especially in the young adult and the adolescent, and if they're the breadwinners of the family, clearly you want to do whatever is possible to try and still give that person a chance of cure. Because an entire family is dependent on that particular person, and thereby all more the need to stress on this, that we don't just easily go and say you go and palliate a 30-year-old, 40-year-old person with a particular disease who's relapsed, and thereby the need for us to look at some of the strategies which will help. So if you look at what are the treatment regimens which are available, there are a host of them. In the earlier days, it used to be only chemotherapy, but in today's world, we have 2 antibodies. The next speaker will talk about Blinatumomab. I am focusing on INOTUZUMAB, both of them available. Now, CAR-T cell therapy is another thing which is coming up in a big way. In our own country, Tata has already started its first patient. There are various other centers who are looking at it, and they're trying to definitely make it affordable for patients who have relapsed cancers. And this is coming up in more than one cancer. It's gone beyond leukemia, lymphoma, myeloma, even in the solid tumors. So clearly there are strategies to try and salvage, and clearly the younger patients are going to do better. So what makes an ideal target when you look at somebody you need to treat with a relapse, especially in leukemia? You need favorable antigenic features, which are, this should not be expressed in the normal cell. There should be a high density of its expression, and high percentage of the blast should express it, which means most of the cancer cells should actually express it so that you have a best chance of killing them off. Here, basically what you're trying to do is sniper shooting, and that is the difference from chemotherapy, which is carpet bombing. So if you're going to do sniper shooting, you need to specifically kill off every single cell. So it has to express your target, which is the antigen, so that your antibody can go and shoot it down. Now, what are the antibodies which we have? The targets are CD20. You have rituximab, which is available in our country, manufactured in our own country. The other two, which are available but not manufactured as of now in our own country, but available. Target antigen is CD19, which is Blinatumomab, and CD22, which is INOTUZUMAB. Now, the CD19 is also a target for the CAR-T cell therapy, and they're using CAR-T cells to target this. There's a lot of data which is coming out. People are talking about cure rates there. A lot of data coming out in children and young adults, and this is also now going on to the older adults. Now, one or two slides about the molecule which I'm discussing, which is INOTUZUMAB. This is basically an antibody conjugate, which means it's an antibody directed against the CD22 antigen expressed on the cancerous B cells. It has got a conjugate, which is N-acetyl-calciamycin. Now, calciamycin is a drug which kind of breaks down DNA. So this is tagged to this, and that's how this molecule works. So CD22 is expressed in most of the patients, more than 90% of patients with B-cell ALL. And this antibody goes and binds it to it on the surface. It is internalized, after which the calciamycin, which is tagged with it, is released. That release happens inside the cell. The moment that's released, this goes and breaks down all the DNA and kills the cell. So nice, neat little mechanism of producing cell kill, specifically the tumor cell. What is the data on this drug? Initial data, phase 2 data from MD Anderson came out with various dosing strategies. Initially, they tried to put all the entire 1.8 mg as once in 4-week dosing. Then they split it up into 3 doses and gave it, and then found that the second dosing worked a little better, was less toxic. And subsequently, that was the dose which was finalized to give it in 3 doses in the dose of 1.2 to 1.8 milligram per meter square. Now, the big study which actually looked at the efficacy of this particular molecule in the relapsed leukemia setting. So initially, the intent to treat subset of patients was about 259. Subsequently, it was 326 patients who were actually followed up for long term. So this got published as 2 papers, the first one in NEJM in 2016 and subsequently in Cancer in 2019, where the long-term data was looked at in the second publication. The initial publication just looked at safety and efficacy of this molecule. So this was in patients more than 18 years of age with relapsed refractory CD20 positive ALL who were eligible for 1 or 2 salvage treatments. They could be either Philadelphia positive or negative, and they risk stratified based on the duration of which their first remission was, whether it was more than a year, less than a year, what was their number of salvages, and their age cutoff. And they were randomized 1:1 to 2 subgroups. The first group got INOTUZUMAB at that dose of 1.8 mg per meter square. It was split as 0.8, 0.5, 0.5 and given at weekly intervals. And the other group got standard of care, which could be the flag IDA, which we commonly use. It could be high-dose RSC with mitoxantrone or just high-dose cytarabine. Various choices were allowed, and that was defined as standard of care. So they were equally randomized to both arms. Now, I won't give you too much data on those numbers. I will just put up these little graphs to show the differences they've observed. So you can just look at the remission rates itself, clearly different between the 2 groups, the INOTUZUMAB arm versus the standard of care arm, 80% versus 30%. You've got a 50% difference there in remission rates. MRD negativity, which is what we all want to achieve in the acute lymphatic leukemias, again, 78% versus 28%, close to about 50% difference there. When you looked at the intent to treat, when you looked at the long term, when the second set of patients were also included, which was totally about 164 patients in each arm, again, that difference stood out a little lesser at 43%, 73% remission rates in the INOTUZUMAB arm versus 30% in the standard care, and MRD negativity in close to about 76% versus 38% in the standard of care arm. So clear differences are very evident here on the response rates obtained by using this antibody-based therapy. Now, the number of cycles you needed to achieve that. So within the first cycle, you had 42 in the INOTUZUMAB arm who became MRD negative. That went up to 80 after the second cycle, 91 in the third cycle. You can clearly see that jump every cycle of getting this antibody. Whereas with the standard of care, which was just chemotherapy carpet bombing, you're seeing the numbers are kind of eventually reaching 19, starting at 13, and kind of plateauing off at that 16 level. So clear difference in the response rates as far as MRD negativity goes. And then when you looked at it over a period of time, if you looked at the progression-free survival, that is in the absence of disease, clearly the INOTUZUMAB arm is at a higher level there, and it's plateauing at a higher level. And you can see the clear difference between the 2 curves here. Duration of remission, again, you can see there's a clear difference there. Longer remissions obtained in the INOTUZUMAB arm against the standard therapy arm, clearly giving you a longer time for you to plan whatever else you need to do later. And the gist of it was that at the end of all of this, you had to get them on to the transplant, because that is the only cure. You cannot maintain it just with this. You need to bridge them with the least toxicity, keep them well, and then take them to a transplant. So clearly you can see that the number of people who actually got down to a transplant, 65 versus 17, clear difference in the two groups. So more number of patients could actually get to transplant, which is ultimately the final cure which you can actually provide, and statistically significant differences between the two. Now, when you looked at the long-term overall survival, they started looking at their follow-ups and looked at their 2-year survivability probability. In the INOTUZUMAB arm, it was 23% versus 10%. And like I showed you in my first few slides, we're all looking at about 25% to max 30% long-term survival. That's the best we have at this point in time in today's world. Maybe with the CAR-T therapy that might get better, time will tell us, and especially when that's available in India and it's done on Indian patients. Now, the next slide shows us the long-term follow-ups, overall survival curves at the 3-year mark. There again, there's a clear difference between the two, statistically nearing significance there, and clearly the INOTUZUMAB arm doing better. Now, what are the side effects when we're using these kind of drugs? So is there a worse myelosuppressive or the drop in cell count, which you see when you compare these two arms? Clearly, it's not as much as standard of chemotherapy. There is prophylaxis with a drug called ursodeoxycholic acid, which is given to reduce the frequency of veno-occlusive disease of the liver, which is one of the complications of this drug. I'll come to that a little later. But this is something which is done very easily, OPD based, especially in today's world of COVID. That's something which is very important, where you don't need to admit the patient. Clearly, lesser number of hospital stay, lesser number of hospital days, lesser cost. So all this will translate into reduction in cost when you look at it from a perspective of being admitted in the hospital. These are the numbers which actually give you that data. And if you just look at the burden of hospitalization, this is just a jumble of data which is all put together to convey the same thing at various cycles. Does the salvage status matter? Yes. So if you achieved a remission with the first salvage treatment, you clearly did much better compared to achieving salvage with subsequent treatments. And when you looked at salvage, INOTUZUMAB produced a better salvage compared to standard of care. The number of patients who were actually salvaged with just 1 or 2 doses of INOTUZUMAB, which were much, much higher compared to the standard of care arm, which is in the 30% compared to about 70% or nearing 80% in the remission rates in the INOTUZUMAB arm. Similarly, if you look at MRD negativity rates, again in the 70 to 77% in the INOTUZUMAB versus standard of care, which is in the 30 to 40% range, depending on which salvage. What about the progression-free survival and overall survival depending on salvage status? Clearly, if you were in the first salvage with INOTUZUMAB arm, the top blue line, you did the best. Subsequently, your salvage treatments was better off in the standard of care arm when you compared it with the INOTUZUMAB given as second salvage. So clearly, your first salvage is your best, and among them, using the drug clearly achieved better salvage rates, both for progression-free survival and overall survival. Now, when you looked at the duration of first remission, clearly people who are in remission for a longer period of time, which means more than a year, did better. If they were more than 1 year in remission and then got INOTUZUMAB, they did the best compared to having it less than 1 year. If you were more than 1 year in remission and then still got standard of care, you almost matched what you got if you were less than 1 year with INOTUZUMAB. So the best bet was if you had a longer, disease-free remission and then got INOTUZUMAB, then clearly that was the subset which did the best. Overall survival by salvage status, again, like I mentioned, the ones who were salvaged in the first salvage clearly did better than having to go through a second salvage and then kind of plateau as far as survival goes. Again, the salvage status was not enough just by the chemotherapy itself. You had to top it up with the transplant. So in your first salvage, if you directly proceeded to transplant, you did the best, which is the top blue line. Your 24-month survival probability was about 45%. Whereas if you did not proceed to transplant, it dropped to 15%. Whereas with standard of care, if you again went to transplant, you still did better at about 37%. So clearly transplant is the only option with whatever salvage you did. But clearly among the salvages, the monoclonal antibody did better compared to the chemotherapy arm. How important is achieving minimal residual disease? So that is a clear indicator now in today's world. Everybody looks for MRD status, and clearly the ones who are MRD negative are the ones who do better and get long-term cure rates compared to the ones who have MRD positivity. And thereby there are strategies to get people MRD negative before you take them for transplant, because that's a good indicator to say that if you are MRD positive, you would then have a higher chance of relapse. So clearly that becomes a defining status on how you then subsequently progress to transplant. If you're MRD negative and you have a transplant, you did the best, clearly almost reaching 40% survivals. Whereas if you were MRD positive and had a transplant, that was almost equivalent to being MRD negative and not having transplant with the chemotherapy arm. So these are kind of almost touching each other there. But if you're MRD positive and you didn't get transplant, there was almost a very minimal chance of survival, less than 5%. What about disease burden? When they looked at the bone marrow disease burden at diagnosis, when they were initiated in therapy, whether it was less than 50%, 50 to 90%, more than 90%, it made a difference when you were getting chemotherapy, because when there is chemotherapy, you have more cells to kill in your carpet bombing. So clearly, if you had more cells at the beginning beyond 90%, you didn't do as well, whereas if it was less than 50%, you did well. However, this factor didn't matter when you use INOTUZUMAB because of its selective ability to kill off the cells. It is 70% across the board from the response rates. Similarly, MRD negative rates are also in the 70 to 80% for the INOTUZUMAB arm, whereas it plateaus at the 30-40% range for the chemotherapy or the standard of care arm. CD20 expression level, clearly, obviously, the ones expressing will do better because you're using a target which is against that. So clearly, you can see all those response rates in the 70-80% in the INOTUZUMAB arm because you need that expression for the drug to work. MRD negativity by CD20 expression, again, clearly better in the INOTUZUMAB arm because of the higher cell kill which you achieve. What about the pH positive, or the ones who have the pH positivity, for which we have another drug, the tyrosine kinase inhibitors, which are available, which can also be an additional to your standard of care as an add-on. Clearly, that helped if you were pH positive, because but it never got as close to as what rates were achieved in the INOTUZUMAB arm of 70%. You got about 55%, which was better than the ones who were pH negative, because they didn't have that additional drug, which was another mechanism to achieve cell kill. Similarly, if you look at the MRD negative rates also, it was better in INOTUZUMAB versus the pH positive patients, even though they had the TKI as a specific drug to actually produce cell kill by using a targeted therapy. What about stem cell transplant? About 77 of these patients in the INOTUZUMAB arm actually could proceed to transplant, whereas only 33 in the standard of care arm could proceed to transplant. Some of them required additional treatment, about 6 in the arm and about 15 in the standard of care arm required a second round of therapy before they proceeded to transplant. But clearly, that's the only way to get them to a cure. And this graph clearly shows that the ones who were followed up with a transplant in the blue line are the ones who actually did well long-term, plateauing at that 40% range at the end of about 36 months, compared to the ones who didn't. And you can see that curve dropping there in the ones who did not receive transplant. Now, my last few slides will be on a complication called veno-occlusive disease of the liver, which is a complication which has been seen with the usage of INOTUZUMAB, especially in people who've been heavily treated with a lot of chemotherapy, have some liver issues, liver function test abnormalities, or some features of chronic liver disease. They are the ones who tend to have more of these complications. So the ones who proceeded to transplant in the INOTUZUMAB arm, about 22% of them actually developed VOD of any grade, and the mean duration at which they developed it was at a duration about 15 days. So clearly, we need to be aware of this complication when we take these patients for transplant. And as a transplanter, you need to take adequate precautions to prevent this. The ways to prevent this, or the risk factors which predispose to this, are the usage of dual alkylators during conditioning, and thereby you would want to avoid the usage of dual alkylators in your conditioning regimen. If the baseline bilirubin or the liver enzymes are already up, then you're more likely to get it. So you need to be more aware. You need to definitely avoid drugs which are toxic to the liver so that they don't become an add-on to produce more trouble to this problem. There are clearly definitions, criteria laid down as to what you call veno-occlusive disease. I won't go into that. And there are ways to actually prevent this. You use a drug called ursodiol. You avoid hepatotoxic drugs. And if you could proceed for transplant within 2 cycles of using INOTUZUMAB, then they found that the chance of getting VOD are much lesser compared to if you gave 3 or 4 cycles of INOTUZUMAB. From our own experience, most of them do go into remission after 2 cycles of using INOTUZUMAB. So to just summarize with my last slide, the gist of what I wanted to say is that clearly the antibody conjugate is clearly superior to the standard chemotherapy which we are using in relapsed acute lymphatic leukemia. And clearly the first salvage is your best option. Once you get remission, direct transplant is your best chance. And with that, you can get close to about 30 to 40% cure rates. And you could use TBI conditioning regimen, but you need to be careful in your conditioning regimen to make sure that drugs which can predispose to veno-occlusive disease of the liver should be avoided so that that complication doesn't come up during transplant. That should be my last slide. I'd like to end here. Thank you.
Thank you, Dr. Sharath. Any questions from the audience? May I ask one question?
Yes, sir.
Is there an optimum number of cycles of INO to achieve the MRD negativity?
Yes, sir. So they've described the 4. That's why I put up those 4 cycles. But from the data and from the having a discussion with the person who was actually involved with the INOVATE study, he says most of the time it's 2 to 3 cycles. And a good majority of them will go into complete MRD negativity after the second. And that's the same experience we've had with our few patients where we've done it. And once you achieve that, then you can straight away go ahead with your transplant plan. So that's what is the best recommendation.
Second question I have is there any CNS penetrability? If there is a CNS involvement in the relapse setting, does it take?
So they've no, there is no evidence that it will. So you need to, so that's why they've included in their first study, they've included CNS negative patients. So thereby they've not included that subset. You'll have to clear the CNS before you take.
Is there any data of post-transplant maintenance with the INO?
Not that I know of, sir. Definitely no, not used also.
Right. Any questions from the audience, please? If none, then Sharath, thank you very much. Very elegant presentation, comprehensive. You covered the subject beautifully with your personal experience.
Thank you, sir.
Thank you. We move on to the second speaker, and we have Dr. Satyendra Katewar. He is a hemato-oncologist, Manipal Hospital, Jaipur, and the subject, of course, is the other antibody, Blinatumomab.
Good afternoon, everyone. So, as Sir has described, I will be talking about the other one, that is Blinatumomab. But before that, let me thank the organizers and for giving me this opportunity. The topic is very near and dear to my heart because it's kind of some good news in the world of refractory leukemias. So we are going to cover what exactly is Blinatumomab and why do we need it.
Sir, can you convert it into a slideshow mode?
Yeah. So what's then the agenda for the talk would be, the first one we are going to see what exactly the Blinatumomab is and why do we need it. What's the efficacy categorically into the children and young adults? And can be, there is a lot of talk about this much can be done with Blinatumomab. Why do you need CAR-T cells? Or why do we use Blinatumomab? CAR-T cells are not going to be available and all that. So we'll have 1 or 2 slides about that. Can this be used for high burden disease? Because the canonical thought process about INOTUZUMAB and Blinatumomab is that INOTUZUMAB is for the higher disease burden, and when the disease burden is less or towards the MRD positivity, Blinatumomab is a good idea. But can we do something differently? And is it really making the difference in the long-term survival categorically of the young adults? Because here we are, talking about the teenagers and the young adults. If there are a few future questions which I will be touching upon if the time permits, and I have nothing to disclose. So that's what exactly the Blinatumomab is. It's a real immunotherapy, but there is a combination of 2 antibodies. So one antibody is against the CD3 cells, and the other one is against the CD19, which is present almost on the whole B-cell malignancies. And then you link them with a linker, non-immunogenic linker protein. And the moment you give it to the patient, so it's a very small antibody, the weight is less than 50 kilodalton, and that's 1/3 of a typical monoclonal antibody. And that's where there is some evidence that maybe it might be effective into the CNS diseases as well. Now, these variable domains, once you attach them, CD3 and 19, they put both the cells in close proximity, and that helps into creating a immune synapse. And once both the cells are together, There is an increase into the CD2, CD5, and CD69 markers, and there are increase into the inflammatory cytokines like interferon gamma, TNF-alpha, interleukin 2, 6, and interleukin 10. Now, these activated cytotoxic T cells then induce this perforin into the surface of the B cells, and through that they induce the grain jam into the lyse. There is apoptosis and the cell lyse. There is a differential affinity between the binding of this antibody. So it likes more onto the B cell. So once the one B cell of the blast is goes away, the affinity is more towards the B cells. It immediately binds to the other cells, and the cycle keeps on going. So it's really, really important. The other one that is hypothesis that blinatumomab, it causes a polyclonal T cell proliferation, and that keeps on killing the CD19 cells as and when they come up. So it's a beautiful drug, and it's actually a immunotherapy like INOTUZUMAB, that's a targeted chemotherapy. But here we are talking about immunotherapy. Now, it got approved in 2017 by FDA for adult pediatric relapsed refractory B-cell malignancies, ALL, regardless whether you are Ph positive or negative. And it is the first approved immunotherapy in ALL. Now, that's what the history is. In December 2014, you got some approval for the precursor B-cell ALL, and it was based on a phase 2 multicenter trial, single arm. Then almost after 2 years, you got it for the pediatric refractory, relapse refractory Ph negative precursor B-cell ALL. Again, phase 1 to multicentric single arm study. And then in July 2017, we got the full approval based on these two trials, the TOWER randomized control trials, and then the ALK-ANDORA trial. And based on that, we got the full approval of relapse refractory Ph negative or positive adult or pediatric precursor B-cell ALL. But what interests me the most is the last approval, which came just 3 years ago. That is the expanded approval for MRD precursor B-cell ALL. That means, all three up were when you are relapse refractory, nothing else is coming. But now we have an approval for if you are MRD positive precursor B-cell ALL, you can induce the antibody, and that makes a lot of things. And we will talk about that in a while. Now, why do we need it? Why do we need the drugs like INOTUZUMAB, Blinatumomab? Because, the B cell, to put them into the CR1 is an easy thing, almost 85 to 90%, but still some 25 to 30%, maybe it is slightly better in pediatric, but now, again, the moment you include the young adults, so 1/3 of the standard risk and almost half of the high-risk patient with relapse. And then it's not that easy to put them again into the remission as it is to put them into CR1. So CR2, achieving CR2 is very, very challenging. And then these relapse and refractory ALL patients, they have very lower rates of getting into the CR, and forget about the long-term survival. They are around 40% when we include the pediatric population, but otherwise they are around like 25, 30%. And these poorer rates becomes more poorer when you are talking about the third relapse, the fourth relapse. So it's really, really important when the patient is not getting into the MRD, we need the MRD. And why it is important, that's where it is. It's a meta-analysis. And that is the most beautiful meta-analysis regarding the MRD and ALL I found. Some 39 studies, 13,600 patients, and they have categorically proven that that's why you need it. So you see categorically, here is for the pediatric patients for the event-free survival and overall survival. If you are MRD negative, your outcomes are beautiful, more than 75% versus MRD positive, you come down to 20%. And similar way in the adults also, you are slightly less than 75% when you compare with the pediatric, but still between 65 to 70%. But if you are MRD positive, then you go down to less than 20%. So this meta-analysis categorically proven that you need MRD come what may if you are going to talk about the survivors and event-free survivors. And that's where the historical perspective, what we know is not the truth. So we started way back in 2001 into the NHL patients. And at that time, we were not that smart. So we gave just 2 or 4 hourly intravenous infusions. And all 3 trials were terminated prematurely because, there was lack of any objective clinical response. There were a lot of neurological toxicities, CRS and infections. And looking at the half-life of 2 hours, then it was thought that maybe we are not giving it appropriately. And then it was decided to start the 24-hour infusion. So then 2004, after 3 years, we started multicenter trials, and the Germans took the lead into that. And then we started 24 hours IV infusion of blinatumomab in patients with the B-cell malignancies. 42 patients received treatment in dose escalation phase, 4 to 8 weekly. And the maximum ATD they decided was 60 microgram per meter square per day. Now you will see there is a lot of difference in what we now say MTD, and at that time, it was the first one. And there were a lot of neurological toxicity. But first time they proved that overall response rate was 69%, with one third of them were just CR negative. So this was phenomenally good, but a lot of neurotoxicity, and few of them were very, very serious as well in quarter of the patients. That was the first one, and most of them could actually resolve or they got better. So ultimately, there were toxicity with this MTD, but they proved that there is response. So this was into, and now the first step into the German multicentric ALL study group, GMALL, open label, multicentric, single arm, exploratory phase 2 trial. And here, the Max presented the data first time into the ASH, and it was a buzz into in the whole scientific community. 43 cycles in 18 patients, and the range was from 1 to 5. But median on average was like 2. 12 out of 18 patients went into CR with the first 2 cycles of the Blinatumomab, 67%. And out of these 12, 3/4 out of these patients who went into CR, 75% had MRD negative CR, so very deep remission. And they had patients with 411 translocations, the pH positive ALL as well. And out of these 4 responders went into the allogenic HSCT, 1 relapse with CD negative, the hematological relapse, and the 2 responders later on extramedullary and the isolated, the marrow relapse they also presented. But the remaining 6 non-transplanted, they stayed well. So this was the first time the GMALL showed that, there's a good response and the patients do well. And then it was later, from the ASH, the oral paper, it was a paper full-blown, published. It was 36 patients rather than the 18. And still they showed that some 69 to 70% response after 2 cycles. And some 88 to 90% was molecular remission after the Blinatumomab. And it was very, very noticed that the quality of response was bad if you are not into this first relapse. So first relapse was the best time when you should have given the Blinatumomab, and then after second and third, the response kept on going down. So first pediatric experience comes from the Germans again, Professor Rupert Hand-Rettinger. So it was into the post-transplant setting. So they had 9 patients where they had transplanted, and they again had CD19 positive relapse. And you see into the last corner, few patients, 1 patient was into the 4th relapse, 2 had 3rd relapse, 5 patients had 2nd relapse. So very difficult patients. And you look at the number of transplant they got, few patients with just 1 MRD, few patients with haplo, but look at these patients, matched sibling followed by MRD, cord blood followed by haploidentical, matched sibling, MRD, and haploidentical. So these were the patients with a lot of chemo and the transplants and the things were given. And that's what they proved, that 9 patients that treated with 18 cycles on an average 2. And out of these 9, 6 achieved CR, 4 with 1 cycle of Blinatumomab and the 2 with 2 cycles. And the 3 did not respond at all. And out of these 6 who responded, 4 went successfully transplanted. And overall, they have said that, if we follow this strategy, post-transplant relapse with Blinatumomab, still 1/3 of the patients you can survive and block. Now, major toxicities were again the CNS and some CRS, but there was nothing life-threatening. And then phase 1 and 2, again, the European and the North Americans got together. And I have also worked for these patients when I was in Canada. So this was phase 1, phase 2 trial. So in phase 1, we had 49 patients, phase 2 had 44 patients. And here, for the DLT was the MTD, the maximum tolerated dose was established with 15 microgram. And in this also, the first week, the dose is 5 microgram per meter square per day. And the rest 3 weeks you give by 15. And that is how the 1 cycle of 28 days. Now, 17 patients overall received the recommended doses, and 50% could achieve the MR. And out of this, they went ahead and did the transplant. And some 1/3 patients were, staying alive. And so the most common, again, the toxicity was the blood toxicities were grade 3 or more, but that was nothing. No patient had died because of this toxicity, but there was some CRS and the CNS toxicity again, but none of them was life-threatening. Then because so much is happening into the pediatric thing, so then how come Professor Locatelli is not there? So here he came with the RIALTO trial, Italian and Germany data, 110 patients, more than neonate to less than 18 years. And it was either the second or later relapses. All patients were blast, either obviously the relapse or MRD positive. The dose was same 5 and then later on escalated to 15. Out of 110, 69 patients had CR with the first 2 cycles. And out of this, 2/3 of the patients went into the LO-HSCT. And that's how he said that if you have responded MRD negative, then your chances of long-term survival is probability of the relapse-free survival is around 50%. And if you had given the transplant versus no transplant, your chances are much better with transplant. So Professor Locatelli here established that, blinatumomab, good idea to give it and you use it early, but definitely followed by transplant. Now, here is a question that, blinatumomab versus CAR, can we use, should we use? There are a lot of questions. And the question comes because everybody, whenever we talk about CAR-T cell, somebody will come up and say, I know Gaurav is going to talk about it, but just one slide. Everybody going to come say, ultimately it's come down to 30%, 40%. What's the point of spending some $500,000 and, I'm not, what all. But let me show you a latest paper from the Chinese data. So you see it here. So they have some 600 or 700 patients, 686 patients to be very precise. Non-refractory disease, the patients who were not refractory. So here I want the emphasis. So giving blinatumomab is a good idea, but if it is given into the refractory, here it doesn't work much. In non-refractory patients, it is a good idea because there is a clear-cut difference. And then blasts are less than 5%, then outcome is around like 50%. And then if you give the lymphodepletion with fluency versus non-fludarabine based, so there is a lot of difference. So if you are to use blinatumomab, non-fludarabine is the way to go. And then again, bridge to the transplant is a good idea. You immediately do the transplant and your chances of survival. So let us take the other one. So CAR-T cells are not bad. It is just that how do you use them? Now look at this. So the best possible response with blinatumomab is around 70%. And then out of this 70, some 70% get into the MRD negative, which can go into the transplant. So 70% of the 70 is like 50%. So overall 50% will go into the transplant. And in transplant, at least in pediatric and young adults, we induce some 60% EFSL. And if you 60% of 50, just like around 30% of overall. So CAR-T cell is still at 40% without, but with blinatumomab and transplant, it's not that you are much better than CAR-T cell, you even come down to that. So it's a good idea to use blinatumomab, but blinatumomab also has got the financial toxicity. One cycle comes around 17 lakhs and you need at least 2, and then followed by the transplant, so some 65, 70 lakhs. But even CAR-T cells are very cheap, but we are hoping that in India, we'll be having somewhere between 20, 25 lakhs and then transplant. And then maybe a good outcome. So I think we should not be comparing. CAR-T cell is a different ballgame. Here the patients are very, very refractory. And in blinatumomab, what we are seeing, the good things are where you use it early and the outcomes are better. So to me, CAR-T cells and blinatumomab should not be compared. And you can have a discussion, but to me, they are two different things. Now, can we do something good about the high burden disease with blinatumomab? Because again, the traditional teaching is the blinatumomab means the low disease burden, and then you go ahead and use the blinatumomab. So here is the famous data, again from Vasudhara, the UK data, and that was presented to TYAS. And they had some, based on these two studies, they formulated their hypothesis that if you have less than 50% blast versus more than 50%, your outcome is definitely different. And then if your CR is with MRD versus MRD positivity. So that means if your CR is with MRD positive, your chances of responding to blinatumomab are much better. And these two studies established their thought process that response and toxicity of blinatumomab actually correlate with pre-disease burden. So then they search for the national survey. They dig out some 11 patients. Again, there is a lot of bias because it's a retrospective data. And they had an age range from pediatric to young adults. 3 were infantile ALL, 1 was with Down syndrome, and none had CNS disease at the time of blinatumomab was given. And they give the debulking chemotherapy to these patients. And the debulking chemotherapy was significant. UK ALL 2011 regime A or C, UK ALL R3, Interfent 06 or NOFO high-risk blocks. These are all strong chemotherapeutic regimes. And the dose, then later on, they used the Blinatumomab. And when they used Blinatumomab, everybody was, everybody became with this debulking disease MRD negative. So when they gave Blinatumomab, everybody was MRD negative. And out of these 11, 9 went for HSCT and 2 were awaiting. And they just reported just grade 1 CRS and 1 had grade 1 neurotoxicity. And now they have extended into the prospective trial. So this was something that, okay, if you have a high burden disease, you want to use Blinatumomab, okay, use a debulking chemotherapy and then you use it and then you do the transplant. So it's all good about blinatumomab, or there is some failure as well. So yes, here is the article just few months ago into the March 2021 into the JAMA, and the author is Patrick Brown, and they have reported the effect of post reinduction therapy, consolidation with blinatumomab versus chemotherapy, and the impact onto the disease-free survival in children, adolescents, and young adults with first relapse in B-cell lymphoblastic. It's a randomized controlled trial. So right after the first, relapse, they did the induction, and into the reinduction, they have used either blinatumomab or the standard chemotherapy, and that's what they have done. So here it's like if you use this strategy, the blinatumomab outcome looks far better than chemotherapy, but there was a premature termination of this study, and the author concludes that it did not result into the significant difference disease-free survival. However, interpretation is limited by the early termination and the possible underpowering of the primary endpoint. So initially it was decided that all the patients in both the arms will go on to the HSCT. So why did they terminate, and why the authors are concluding that you see some difference, but we are not convinced it is the true? That was the reason. Because in the blinatumomab arm, so remember, they 100% had to go for the transplant. But in blinatumomab, 70% went ahead with the transplant, but in chemotherapy group, just 43%. So there was a gross mismatch, and the planning, whatever was planned into the study could not be. So it was premature terminated, and they just, onto this paper, there is a beautiful conversation into the same journal by Matthew Fowler, and there is no disease-free survival benefit seen with, blinatumomab when you compare with the chemotherapy. So again, I'll say, don't go by this, because this has not been, unfortunately, we have not been able to finish the study the way we planned it. But yes, there is a good chance that maybe in young adults and all that, it might not be as bright as it looks like. So now the second last slide, the thoughts. So why there is a difference in the response of blinatumomab in patients who is in CR1 versus CR2 versus CR3? So does, and these are the future research questions. That's why I want to touch upon. So does the more prior chemotherapy makes the lymphocyte proliferation poorly? So does that mean that we need more healthier T cell when we induce blinatumomab, because blinatumomab can help kill the B cells, or just the tumor has become smarter the way it becomes smarter with the chemotherapy? So chemotherapy just means the tumor, all about tumor and the sensitivity of chemo, but in immunotherapy, it's more than tumor. Primary player is now the cells. So do we need healthier cells when we are talking about immunotherapy? So maybe you induce blinatumomab way up rather than using it after 3-4 cycles of chemotherapy when the T cells or the lymphocyte have been damaged badly. Now there was a beautiful abstract into the extract where they use blinatumomab plus PD-1 inhibitor, 8 patients from Johns Hopkins, and they produce some 80%. And these were very bad patients. So, but that again, there is a possibility. Now there is a talk about blinatumomab should be used and then followed by CAR-T cell, and there is a lot of conflict about it, because if you use blinatumomab, then probably you are going to have the loss of the antigen. But if these patients are still positive, then there is no question, because then there is no question of CAR-T cell will not be working. But if they become CD19 negative, then should be using the CD19 CAR-T or CD22? And there are people who think both were okay, because even if you use CD19, maybe with the less disease burden, the CAR-T cell also do better. Or maybe you can use CD22. So these are the future questions. And the take-home messages are good drug with less burden, but should be followed immediately by transplant. With higher burden, yes, either we have to use INOTUZUMAB or a debulking chemotherapy, and then you go ahead and do the transplant. We should not, how do we place them with CAR-T cell before, after? the very, very interesting question. Probably the future trials will answer, and we need more randomized controlled trial. I thank you for your time, and I'm open for the questions. Thank you.
Thank you, Dr. Satyendra. Beautiful talk. Discussion, any questions? Dr. Satyendra, is there any data on Blina in children or AYA as first line after chemotherapy?
Now there are trials opening up, sir. If I go into the NCT, there are, but there is no published data as well.
Can I ask a question there? One quick question.
Sir.
Satyendra, wonderful talk. Thank you very much. My question to you is, is there a possibility of combining the two agents for the patients who don't go into MRD negativity, can you follow the Blina with CAR-T cells or the other way around?
So the adults feel so, sir, that the Blinatumomab should be given and then it should be followed up by the CAR-T cells. But the pediatric transplanters, so the pediatric immuno-oncology group has got a lot of reservation against it. But that's what I was saying, that Blinatumomab, even if it induces CD19 negative disease burden, then giving CAR-T cell might still be okay, because ultimately, if you see this 70% response rate comes down to 20%, that means something comes again. So with this less effort disease, the adult physicians, the colleagues are suggesting giving CAR-T cell is not a bad idea, because here now the disease is to the nadir. But pediatricians feel like it might not be that smart an idea. So they are now, maybe if Blinatumomab may be a dual or CD22 is the answer, but definitely the heat and the debate is on, and Dr. Gaurav can answer that, who is going to be speaking after me into this topic.
Thank you. So we'll move on to the third presentation, and that's Dr. Hemant Malhotra himself. Dr. Hemant Malhotra is Director Oncology Services at Shri Ram Cancer and Super Specialty Cancer Center, Professor and Head Department of Medical Oncology, Mahatma Gandhi Medical College Hospital, Jaipur. And he's going to speak to us about chronic myeloid leukemia in young.
Thank you very much, Honorable Chairperson. Many thanks to the organizers of this meeting. I'll try and focus today on the teen and young CMLs. A few slides of introduction, like greetings from the Shri Ram Cancer Center at the Mahatma Gandhi Medical College Hospital. And this is my medical oncology team. Very, very proud of these gentlemen and lady. And two of these, Dr. Prashant Kumbhaj and Dr. Ankur Punya, have been trained by Colonel Chitalkar, their DM from his center, and they're doing a wonderful job with me. Thank you, Colonel Sir. And again, I'd like to start with paying a tribute to my very dear friend, Dr. J.S. Bhattacharya, and one of the founder members of the TYAcan.
So sorry to interrupt. You are not audible.
I'm not audible at all?
Not audible properly, sir.
Okay, I'll get a little closer to the mic and I'll try and speak a little louder. Is that better?
This is better.
Okay, great.
And
so,
do you have a fan on towards you, sir?
I do. Should I put it off?
Yeah, please, sir.
Okay, 1 second.
Thank you.
So I'll have to speak in the heat, but that's okay. Is that better?
Yes, sir. Thank you.
Okay, great. So like my tribute to the founder member, one of the founder members of TYAcan, Dr. J.S. Bhattacharya, and my very dear friend. Also like to remember Dr. John Goldman, who got me interested in CML. So a few slides of introduction for our young colleagues. CML is a chronic myeloproliferative disorder of the pluripotent stem cells. There is increased proliferation, decreased apoptosis. The Philadelphia chromosome is the hallmark, the cytogenetic hallmark, and the BCR-able translocation is the molecular hallmark. And you can see the Philadelphia chromosome over there. A piece of chromosome 19 goes and attaches to chromosome 22 and produces this Philadelphia chromosome. These two genes come in juxtaposition, and the new gene formed, BCR-able, has tyrosine kinase activity. It secretes 210 kilodalton protein, which leads to the full pathogenesis and the syndrome chronic myeloid leukemia. It has three classical phases. We are all aware of that. But I think what is more important to realize is that in our country and other low and middle income countries, we diagnose the disease later in the chronic phase. And this has clinical implication in the sense that at this time when we diagnose the disease, there is quite a lot of disease burden, and there is also possibly accumulated additional genetic abnormalities which lead to some issues and some problems in our cytogenetic response and in our molecular responses. So now let's come and focus on the CML in children and teen and young patients. These are less than 10% of all cases. average age of CML diagnosis in our country, as it is 1 decade less than the West. Now, there are several issues when you talk about CML in children. The first and foremost is how valid are adult-derived response landmarks and time to reach them. There are some issues with dose and dose formulations of oral TKIs in children. Are there any age-specific differences in pharmacokinetics of the drugs, the magic bullets which we use in the disease? And compliance is a big issue, and special attention needs to be paid to making sure that the patient takes his drug, which can be an issue in young children, can be an issue in adolescents. Those of you who have adolescent children will realize how tough it is to get through to them. Then, you know, these patients, if you plan to give them TKI for the rest of their life, they have several decades of exposure to the TKI. And then with this, very long-term side effects, you know, are a major issue. There is a school of thought which feels that why not do stem cell transplant upfront and get rid of the disease, and we'll, you know, see if we can discuss this also. There have been several studies of pediatric patients from our country. This was a publication in the South Asian Journal of Cancer, about 50 patients from Dr. Senthil Rajappa's and Dr. Raghu's group at the Nizam. This was a recent publication, like a large publication from North India, the All India Institute group, led by Dr. Samir Bakshi, 120 plus patients with pediatric CML. So these make interesting reading. Then internationally, some other, a snapshot of some other important publications in pediatric and young adult CMLs. 40 patients, again, they conclude that response at 3 months, as we have for the adults, we can predict outcomes in children also. And again, children who don't have optimal molecular responses at 3 months and 6 months may not have a good outcome. This again is a publication in the Annals in 2014. Small number of children, 120 patients, less than 30 years of age. And you can see the cytogenetic and molecular responses over here. Again, and the same publication, they did conclude in the CML4 study from Germany that younger patients with chronic myeloid leukemia do well in spite of poor prognostic indicators, and you can see the survival curves over here. And the undotted line over here is complete cytogenetic responses and major molecular responses, not too much different from the other cohort of patients. Another publication on highlighting the difference of the disease in young adults and elderly. In their cohort, they had a significant number of patients less than 30 years of age. And again, they estimated that the probability of CML-related survival is unrelated to the disease group, other than the very elderly, more than 60 years of age, who don't do as well as the other groups. Again, analysis of outcomes of adolescents and young adults with upfront TKI, about 60 odd patients, and a reasonably healthy complete cytogenetic response rates, major molecular responses, and deep molecular responses, quite comparable with the older patients. This was a very key article in 2019 in Blood on how to look at the various aspects of treatment of CML in children and adolescents. This is a recent, very recent article in Cancers in 2021. So what are the special issues of treating patients of chronic myeloid leukemia in the young patients? I think one needs to keep in mind the skeletal long-term toxicities of the first generation TKI imatinib. And there is evidence to point to us that for patients who have several decades of exposure to CML, there is a decrease in body height in children. So if you have a patient who's receiving several years or several decades of imatinib, you have to look very carefully at bone markers, and possibly these patients need to be given calcium and phosphorus supplementations. And again, this was one study which very clearly showed that there is a significant decline in bone resorption over time, as indicated by urine DPD. And then again, this kind of tells us that looking at bone health in the younger patient is extremely important. Now, what is the dose of the tyrosine kinase inhibitors in children? We know that for first-line treatment, imatinib, nilotinib, and dasatinib have been approved. Imatinib has the maximum number of patients and the largest data for us. And 3 doses have been used. You can see the number of patients over there. And finally, the consensus is, and this is the information from the Gleevec product insert, in pediatric patients, the approved dose is 340 milligrams per meter square per day. There are liquid preparations also available of all the 3 agents, or you can make them into a liquid preparation for very small children who have difficulty in taking the pill. Now, this is the algorithm for approaching patients. First of all, for patients who were given first-line imatinib, for the patient who does not achieve, who has suboptimal molecular response at 3 months, you wait and watch for another 3 months and then make a final assessment. If the patient is still not in optimal molecular response, then the patient should be shifted to either nilotinib or dasatinib. If the patient has failed imatinib, either because of resistance or intolerance or poor adherence, the approach is different. In case of adherence, you have to counsel the patient again and continue imatinib, and make sure that the patient continues to take the medication. If there is intolerance or grade 3, grade 4 toxicities, then you can switch to one of the second generation tyrosine kinase inhibitors. If there is resistance, then you look for kinase domain mutations. About 50% of patients, you will find a kinase domain mutation, which will help you guide which second line TKI to give to the patient. If there are no kinase domain mutations, you have a choice of giving either of the 2 second generation TKIs, nilotinib and or dasatinib. And in case there is progression on the second generation TKI also, then you have to think of an allogeneic stem cell transplantation. For the patients who received second generation tyrosine kinase inhibitors, again, you have to then switch between the 2 TKIs. The patient has received nilotinib, you can try dasatinib, and vice versa, and you think of a transplant sooner rather than later. Now, this is important. Non-compliance in the younger patient, in the child or in the teenager is much, much more common than in any other cohort of patients. And there is a detailed recommendation for physicians and recommendation for patients as to how to improve compliance. And the moment you see suboptimal response to imatinib, or you see a loss of molecular response to imatinib, the first thing which should come to your mind is to check for compliance. And these are some of the pointers and things which you could do to increase compliance. Then, because you have a growing child, you have a body which is still not completely mature, recommendations have been laid down for monitoring endocrine toxicities when you use TKIs in children and adolescents. So you have to look at the growth very carefully. You have to assess height and weight at each visit, close monitoring of growth velocity. And in case you feel that there is growth retardation happening, you have to pick it up quickly, and you have to refer to the endocrinologist or the concerned specialist for possible GH stimulation testing. If you detect, you have to look at and try and see if there is any problem with bone metabolism, if there is dysregulated remodeling or altered calcium phosphate vitamin D metabolism. you might have to get an DEXA scan done and again refer to an endocrinologist for appropriate intervention. Small number of patients with TKI, maximum with dasatinib, can develop hypothyroidism, and it is recommended that after initiating treatment within the first or the second month, one TSH level should be done and a free T4 level should be done, and henceforth it should be done at least 2 times a year or at least once a year. And if there is any abnormality in the thyroid profile, then it does make sense to involve an endocrinologist in the treatment. Gonadal functions could lead to delayed puberty, gonadal dysfunction, possibility decreased fertility. And again, a Tanner staging is recommended at reasonable intervals. You have to check for gonadal hormones and steroids if there is a delay in puberty, and then refer to the appropriate expert. Pregnancy outcomes, we are pretty much familiar with this. If the TKI is on during fertilization or during the first trimester, there are chances, significant number of chances of fetal abnormality. All patients of childbearing age should be counseled to use a foolproof contraception. And in case the patient does get pregnant while on TKI, the best recommendation is to talk to the patient very carefully and possibly offer a medical termination of pregnancy. And once an adequate duration of TKI and an adequate deep molecular response has happened, then you can attempt a treatment-free remission and then counsel the patient for pregnancy. The indications for allotransplant in children in the TKI era are a little more aggressive than for the adults. However, the consensus is not there. For patients who have advanced phase, either accelerated phase or blastic phase, the initial treatment should be with a second generation TKI. And if a donor is not available and milestones are achieved, TKI could be continued under monitoring. If the patient progresses to accelerated phase or blastic phase, then a second generation agent should be tried and preparations should be initiated for a stem cell transplantation. For patients who have resistance to TKI or unacceptable tolerance to all the licensed drugs which are approved for CML, or if there is the dreaded T315I mutation, then with an intervening period of ponatinib, if available, a stem cell transplant should be done. There is no data of the third generation or fourth generation tyrosine kinase inhibitors like asciminib in patients with children. So maybe we are waiting for the availability of asciminib and the data with children. What about the treatment-free remission in pediatric CML? This, is the buzzword in adult CML these days. What is the status in children? Theoretically, it is even more important in children and young adults because we are looking at several decades of anticipated exposure to the TKI with the consequent long-term toxicities. And each of the 3 or 4 drugs which are approved for CML, they have long-term toxicity. So this is indeed important. And we know that, and this is important because in addition to the on-target effect of the TKI on the BCR level, there are several off-target effects. And, this is the kinogram of imatinib and dasatinib. So in addition to ABL over here, you can see that the TKI impacts so many other kinases, produces a whole bunch of toxicities. And particularly if a patient is exposed to the TKI for several years, they become significant. There have been very few studies of TKI in children. However, attempts are being made. The same guidelines as which we use for adults are being used for TFR in children also. And this is one recent study of 18 patients carefully offered the TFR. And again, as what we have seen in the adults, about 2/3 of the patients or 60% of patients after an initial period of relapse of 6 months, they do tend to stabilize. So TFR is something which is continued to be studied in children also. So you're aware of the International CML Foundation, and if you go to the website of this ICMLF, there is a full section on pediatric CML. So if you want to increase your knowledge about pediatric CML, you could go to this website and do that. There are also case discussion forums, and you could post your case and expect an answer from a world leader in CML within 24 hours. So if I were to summarize my last 2-3 slides, CML in children and young adults is uncommon. Natural history of the disease is probably the same as adult CMLs. However, strong guidelines are not available, and most of the recommendations have been adopted from extrapolation from adult guidelines. How accurate this is, we are not very sure. The standard first-line treatment remains tyrosine kinase inhibitors. 3 agents are approved in the first line: imatinib, nilotinib, and dasatinib. Close monitoring as for adults is mandatory, so that you can pick up suboptimal response and failure very quickly. As already highlighted, special attention should be paid towards compliance, and this is a major issue in patients who have either a suboptimal response or who have a loss of molecular response. Early stem cell transplantation should be considered after the option of TKI first generation and second generation have been exhausted. Very long-term toxicities, exposure over decades of the TKI are a concern. Patients should be considered for clinical trials regarding stopping TKIs even in the pediatric setting. And again, with good treatment, a multi-decade survival is possible. And possibly once the TKI data is more mature, we might be able to cure some patients without continuing TKI. So ladies and gentlemen, treatment of CML has evolved. Treatment of CML in the child has also evolved. We are learning. We are getting wiser and wiser. And hopefully soon we will have the same outcomes in our pediatric patients of CML as we have for the adults. With that, I'd like to thank you very much, and I'll be happy to take any questions. Thank you.
Thank you, Hemant. That was great. Questions?
Can I ask questions?
Please.
Yes, sir.
Wonderful talk, Hemant. I wanted one question. One of the slides was showing that a young male, you will like to do sperm examination before starting imatinib. But there's plenty of data to suggest that males can actually father children safely while on imatinib. So what is your take on it?
So there is no issue of teratogenicity in males fathering children, but there is some loss in sperm count in males. So in case the patient is not able to father a child, then that may be one of the investigations you may want to think and consider. Otherwise, it is pretty much established that teratogenicity-wise, a male patient with CML can father a child without any added risk.
Yeah. Having said that, many of our patients come late, say 9 months, 12 months down the line. So the disease also will cause kind of poorer sperms, no, in the first, at that point, if you actually see.
Absolutely. Absolutely correct.
And just as in passing, have you had an experience of asciminib, just for curiosity?
So I have 3 patients who have the T315I mutation, and I've sent their documents to Novartis for compassionate access. We haven't got the drug for any patient as yet. So we are waiting. Maybe Dr. Agarwal has some experience with asciminib. I don't have any hands-on experience.
Not really. I mean, in this situation, we have used ponatinib freely because that's what is commercially available at the moment. But yes, you're quite right. We don't have any experience of this molecule. In view of the long-term toxicity of drugs, and you quoted one paper from New York of Nobuka Hizaya, where nilotinib has been extensively used in their center upfront, first line for children, and after 3 years of deep molecular response taken off and with 60% TFR success rate. Would you recommend that in pediatric patients where there is no issue of cardiac problems, nilotinib may be a drug of choice?
That's a really tough question, sir. I would be most comfortable with imatinib if the patient is tolerating it and if the patient, is achieving molecular targets, because we have a maximum long-term toxicity data with imatinib. Nilotinib, we don't have data over 20 years, and we do see that there is a gradual cumulative increase in cardiac toxicities over time. So my first choice for a growing child would be imatinib, probably if there are no tolerability issues and if the molecular response is satisfactory.
Thank you, Hemant. We move on to the last talk of the day and of this session. And I invite Dr. Gaurav Narula. Dr. Surgeon Commander Gaurav Narula is Professor of Pediatric Oncology and Health Sciences at TMC, Homi Bhabha National Institute, Mumbai. And he's going to address the subject of CAR-T in youngs.
Thank you, sir, and thank you, Professor Chitalkar, sir, for calling me for this talk. Colonel Chitalkar had requested me to speak on CAR-T cells and also tell us about some of the work which we have done. And in a brief period of 20 minutes, I shall try to take you through that as rapidly as I can, because it's a vast field. I do have a disadvantage compared to the other presenters in that while Blinatumomab and INOTUZUMAB are one drug, CAR-T is really many drugs. So there's really no one thing that I can talk about when it comes down to CAR-Ts. So if you can see my slide, I will. There is a. If my screen can be seen fully, I shall start.
Yes.
Right. So I'm from Tata Memorial Hospital, and I am on the Scientific Advisory Board of IMMUNOVATE. ALL and leukemia and lymphoma, especially in children and young adults, has been pretty much the success story of oncology, especially hemato-oncology. And we have seen now how improvements have occurred over the decades, now well into the 90 and even 95% and above now, overall survival being achieved in the global north. But outcomes in India have remained close to the 70 to 80%, which is pretty much what was achieved over there in 3 decades ago. And while we have been seeing improving outcomes over time, even in our institution, and it's mirrored pretty much across the country, once it comes to relapsed refractory ALL, the outcomes have been very, very poor. This is the same cohort on the left, which we are showing 70 to 80% and above outcomes now. But when they had relapsed or become refractory, even those who were relatively good prognosis, that means they had late relapses, had only around 40% outcome. So there are major hurdles in achieving cure for children and young adults, especially with ALL. When it comes to diffuse large B-cell lymphomas, pretty much the same story is seen again. This is a graph showing the outcomes of refractory DLBCL once they have failed or not responded to the first or second line of therapy, including primary refractory ones, and the outcome is uniformly poor. Adding transplant, autologous transplant, does help to an extent, but not by much. So for diseases which are primarily very highly curable in their primary setting, this kind of outcomes when it comes to the secondary setting is quite disappointing. So what we thought a while ago is that gains from conventional strategies have been maximized and further improvements are going to be incremental, and something needs to be done about this. The reason why B-cell malignancies, especially leukemia and lymphoma, B-cell type have presented themselves as a great target is because of the uniformity in the development and the common presentation of antigens, especially the CD19 antigen, which is seen in most stages of development, except for the earliest one from the B-cell precursor till almost to the centroblast stage, which continued to be seen. And it's only when it moves into the centrocyte and to the lower mature forms that it starts losing this antigen. Along with that, there are other antigens also commonly expressed over there. And this presented itself as a beautiful target for immunotherapies, and all the immunotherapies which have been developed have been more or less following the same principle. Now, when it comes to immunotherapy for B-cell malignancies or actually any malignancy, whether we are using monoclonal antibody mediated or whether we are using unmodified T cells or checkpoint inhibitors, ex vivo expansion, TIAs, or genetically modified T cells, which may be by CAR-T cell or CRISPR, the fact is that it is indeed the drug is the T cell over here. So when we talk inotuzumab, sorry, not inotuzumab actually, because that has a conjugated molecule over there, which is causing the cytotoxicity. But like blinatumomab or any other one of the other ones, the blinatumomab is not doing the killing. It's the T cell which is doing the killing. And the same goes for checkpoint inhibitors. It's not Keytruda or pembrolizumab or nivolumab which is killing the cancer. It's the T cells which is killing the cancer. So what we are doing over here is we are all in different ways, in different sides only in the details. We're trying to harness the power of the T cell to kill the cancer over here. And that is really what this is about. And the options which faced us with whether you should go for transplant or inotuzumab and blinatumomab, and you heard two excellent talks about the use of these drugs and the context of them, or we go with using the T cells themselves, which is modified and can kill it. So this is just a short video which I thought for the younger people over here, which shows how a T cell is engulfing a cancer cell over there. And if you see that, it's quite chilling actually how this perfect system of assassination has been lying and developed over millions of years and is right there in everybody's body. And all we need to do is to just to be able to harness it properly so that it can do the job it was always supposed to do. Now, in the CAR T cell approach, what we are doing is that since they do not have the antibody against T cells, do not and will not express the antibody against the CD19 molecule, we have to force it to do that. And we can do that by transferring a gene into an isolated patient T cell, and you can remove the cells from the body by apheresis, isolate them, separate them, and transduce them, and then expand them and give them back. And this kind of thing caused dramatic tumor responses, as was first seen from this girl, Emily Whitehead, who received it in around 2012. And she had a dramatic response and made it to the cover of New York Times. And that was when all the hype around this started really building up. And we saw a whole host of trials coming up. So the concept of CAR T cells is that you are now they're going to express an antibody which will ultimately in the cell look like this. There's an SCFP domain which will be expressed on the outside, and there's a linker and a transmembrane domain and some co-stimulatory molecules intracellular which will cause the downstream signaling. In the first generation CAR, there were no co-stimulatory molecules, and these cells used to get exhausted very quickly, so they were not potent at all. But once co-stimulatory domains started being added, and you've seen two examples of two over here, and now there are many, many more, the efficacy started increasing dramatically. What we need is to get this gene to be expressed in the T cell. So the T cell is never going to do that in nature. So what we do is that we can take a replication incompetent viral vector, which may be retroviral or lentiviral. These work best, but non-viral methods are also available. And you have developed a gene which will can be delivered by this vector into the T cell, and that will now start making it express the protein, which will then get expressed on the surface, and then it will be able to attack a B cell or any antigen of desired interest. So CAR T cells, basically, they are not a single drug. You don't. They are capable. They are live, so they can engage, they can destroy, and they can proliferate inside the body. So what you give to the patient is only the starting point, and it can expand in vivo to meet the challenge which is there before it, and it can continue to do that for a long time, even before, even after it has been injected. So that's how it essentially becomes different from the drugs which are otherwise engaging the T cells. The first trial, after that, when Emily was treated, after that, the major trial, which was from the Children's Hospital, Pennsylvania group, proceeded. As Emily grew older, the trial also proceeded and continued to show dramatic results. This is patients who were eligible for this trial were mostly relapse refractory, failing 2, 3, 4 lines of therapy, including transplant and blinatumomab. And the results, as you can see, for that cohort of patients is quite dramatic, with 50% EFS and close to 70% overall survival. Emily Whitehead, meanwhile, continued to grow, and she's a young teenage and young adult now, like the audience of this conference, or the target group of this conference, and that's the most heartening point over here. And along with that trial, the number of trials which started rising for CAR-T cell therapy started increasing. And this graph, which was in 2018, which was projecting about 10 trials to be running across the states by the end of 2018, completely dwarfed by what was to follow. And this is a summary of cutoff 31st December 2020, which shows you that there are more than 1,007 trials running across the world in various forms of CAR-T therapy. So, not all of them are different INDs. So there will be about probably 400 to 500 different INDs with maybe 1 to 2 trials of each one running across in different indications. That's a huge amount of innovation which is going on and explosion in the field. And within that field, the vast bulk of them, and this is from about 934 trials, 722 are in the field of hematological malignancies, and the bulk of them, the green and the blue, which you see, are for leukemia and lymphoma. So this is clearly the worldwide favorite for anybody who's trying to develop a CAR-T cell. But there's a geographical disparity in the way this has been occurring. As you can see, if you include Australia in the global north, the trials have been occurring in the global north, and the global south has been completely left out of it. But probably we have been able to make a dent in that, and now we have 2 trials going on with the same IND for leukemia and lymphoma, targeting 3 to 25 years of age in leukemia and above 18 years of age for DLBCL. So, in the lymphoma, along with the leukemia, the lymphoma has also been a success story. And this is a snapshot of the trials which have been led to approvals in lymphoma. And that is 3 products, that's tisantilizil and axicabtagene and lisocabtagene. And they have been approved now for indications over here, for which this is the snapshot of the trials. This was mostly in DLBCL, but also included patients of PMBCL. And now we have also got an approval for mantle cell lymphoma, in which the same product, it's essentially the same product, but only the ratio of CD4 and CD8 or effector cells in the product is assured in a 1:1 ratio, which in most of these other studies has been found to be an ideal kind of ratio. So when you're making CAR-T cells, you don't know what the ratio is going to be, but when they look back at the data and found those which had closest to 1:1 ratio, they were the most effective or had the best responses. And now they are trying to remix that and assure the ratio, which essentially leads to a new product. So this has become a multi-billion-dollar industry. And what has happened over time is that when it started out, nobody knew which way it was headed. But once the first product got approved with a price tag of nearly 3.5 to 4 crores in Indian rupees, depending on the product, it realized that this is going to be out of reach for almost everybody in so-called global south and low middle income countries. Satyendra touched upon this, but the thoughts that we had at that time when we started thinking about how to go ahead with this, huge burden of relapsed refractory patients, what we realized was that if we could go for Blina or Blincyto or drugs like that, which were showing huge, great results outside, that was one way to go. But the problem with these are that they are all pharmacological products or molecules, and they follow the conventional pharma model. It's industry driven. There's no infrastructure required. You buy the drug, give it to your patient. They don't require any skill augmentation, so that's actually good. But you do require some skill augmentation for administering these drugs. It's a buy and use model that's non-modifiable. So the drug is a drug. You take it as it is from the manufacturer, and you have to follow the rules. But it's going to be expensive. So this is something which is you will always have to buy, and there's nothing much you can do about it. As and when they choose to enter the Indian market, only then you'll be able to use it. Until then, it remains an imported and prohibitively expensive drug. But with CAR-T cell therapy, it's more like a process, is the product itself, and it's evolving. Like he's shown you, all these trials which are going on, they're all evolving. Each product is slightly different from the other, or grossly different from the other. And when we say Blina versus CAR-T, we're really not saying Blina versus CAR-T. We're saying Blina versus a whole host of therapies which are roughly similar in that they are genetically modified T, that there's nothing in common. So a comparison is really like comparing apples and oranges. But it requires infrastructure. Infrastructure, it's a because that's where the manpower is lacking. But once you have that, then only you are able to get that. But once you have it, you have the skilled manpower and you have the infrastructure, then it becomes a force multiplier. And it is not just one particular CAR-T which you can make them. You can use these facilities and the skills or the people, your teams which are built up and the infrastructure which are built up to do any kind of T-cell therapy or CAR-T cell therapy in the center. So that's what really made it far more attractive to us. And I also always looked at personally as CAR-T cell therapy as graft versus leukemia without the mess. So basically, you're doing something similar to a transplant, but there's no HLA matching required, no biloablative conditioning, no risk of GVHD. And though it is really called CAR and it gives the image of this really beautiful thing, but actually I always looked at it more like an auto-RIC in the sense that it was an autologous reduced intensity conditioning cell transplant, not even a stem cell transplant. So procedure-wise, it was quite the simplest thing to do. The technological challenge in it is to genetically modify the T cell. So for that, I and Dr. Rahul from IIT Bombay, we got together and said that let's try to do this over here. We met in 2015 and decided to collaborate on this project. And we were able to get the advice of National Cancer Institute and investigators over there in Bethesda, who were knowledge and mentor partners to us. The development occurred in Institute of Technology, Bombay, and the translational work occurred in both our centers, and the clinical trials have now commenced in Tata Memorial Hospital for both of them. And Rahul and I have conceived and planned this from the very outset. And now IMMUNOACT has been set up as an offshoot of IIT Bombay within its campus, supported by the institute, and that is the route which is going to be taken forward to probably bring these products to the general public and everybody at large once they are approved by FDA, which we hope should be happening soon. So the critical thing about CAR-T cells is that there are steps in the manufacturing which are involved. And while you can get the T cells from you need the T cells from the patient, you need a gene transfer vector, which we call the drug substance. So when you compare with the conventional pharma model, this is the drug substance, and everybody has got a different drug substance. So you need a unique design to be able to patent it. And everybody doing a CAR-T, including us, we have to have a unique design over here. So it's really not the same as any other CAR-T which maybe have approved or in under trial. So then the rest of the process is something which is got to occur in a GMP facility, that is the selection of the T cells, their activation, their transcription, their expansion. All this has to occur in a facility which is like a factory clinic. It has to be like a pharmaceutical factory. It has to meet production norms. It has to meet manufacturing laws. It has to be following good manufacturing practices. And this needs to be done in this. And this whole thing is a process. Now, this process actually, even if you change one step in the process, the FDA or the DCGI considers it as a change in the product. So it becomes a new product. So even if I have the same vector, which was developed in IIT Bombay, but if we change this process in between, it will become a new product, which requires a new trial or at least a bridging study very much to go forward with it. So these are the complexities involved. And then in the end, you have the output, which is the what we understand as the drug product. So when we say CAR-T cell product, we are talking about the finished CAR-T cell product, which is the T cells. When we talk about the drug substance, we are talking about the gene transfer vector, which is designed and developed in whatever facility, in our case, IIT Bombay. And the GMP facility is something which is a process, so anybody could have control with it as you have the skilled manpower and the infrastructure. Now, the GMP itself is something which is complex, but basically there are different companies which offer you semi-automated platforms, and there are companies which offer you fully automated platform. And then, of course, the other way is that you make a clean room in which you can do all these steps manually. So we first went with the manual route, and now we are slowly graduating to the semi-automation and the automation route, because that will help to scale up production rapidly. So I'm sorry, yeah. So this is an example of This is an example of this GMP which we have made at ACTRAC. It's a ISO class 7 room, which so floor plan is FDA approved, but we are still to apply for a clinical grade manufacturing license. However, IIT Bombay has already got the license, and we are proceeding with that as of now. The details of the product that we designed. We designed 3 products in IIT Bombay. There were 2 humanized CARs and 1 murine CAR. All of them directed at the CD19 antigen. And this is what it looks like, the protein molecule. And it's a low affinity but binding, but a highly persistent CAR. This next one will show you that it met all the criteria for meeting patent requirements, and we have a worldwide freedom to operate this molecule once it is approved. This is some of the results that we had with it. The left panel over here shows you mice which received the CAR-T product, received the leukemia cell line, and those on the right received the leukemia cell line and the CAR-T product. And you can see that it shows by day 18 to day 31 remarkable reduction in the leukemic burden in the mice which were treated with HCAR19. The spleens in these mice was also normal, the ones who received the HCAR19, while the control ones had grossly engorged the spleens. But then once you have made the CAR successfully, you have to translate it to the clinical grade manufacturing processes and closed system. You can't use pipettes and wells. You need to put it into closed system. And then once you put it into closed systems, then again you have to prove that the CAR-T which you have made in the closed systems meets the norms required for clinical grade use, and that it is effective, and that it is also not going to be toxic. So we had to repeat these experiments with a clinically grade made product and convince the regulator and the RCGM and other authorities in the country that our CAR-T is ready for trial. We also had to show that we had the capacity to expand these cells to clinical grade requirements. So the panel on the left is with healthy donors, and the panel on the right is with patients of relapsed refractory BALL, which would mimic the population which would get this drug ultimately, and we could get even 2,000, 4,000 fold expansion in these patients within 8 to 10 days. The last part of making the CAR-T is to show that it can meet the exit norms, that is release criteria, to be showing that it is safe and going to be safe. So for that, you have to do the identity test, the purity test, the potency test, and the safety tests. All these assays had to be designed and validated and standardized. And once it was standardized, then they had to be shown the results to the regulators. And then they said, okay, you can now go ahead with your trial. So having met these, we were able to publish the data in Molecular Cancer Therapeutics. It made it to the cover story of that journal with the editorial on it. And on 4th of June earlier this year, we were able to infuse the first patient of CAR-T cell in the transplant unit in ACTRAC. And that was a panel above. And a couple of weeks later, my colleague Teeange was able to infuse for the first patient of lymphoma. And this trial is going on in the male building in Tata Memorial. So at both the campuses, we have 2 ongoing trials now. I will not be able to give you any details about the trial yet because that is still confidential and it is ongoing. I hope to have data for you by early next year. But the way ahead is something which we still have to think about. And having got this far, there's no point in stopping. We see this that we have done some capacity building, we've got infrastructure and personnel. So we need to bring the next line of CARs into line and also expand the field of cell therapy per se. And we need to find out ways to collaborate with industry and other cancer centers, and also to educate, because IIT Bombay and PMC are all academic centers. So we should be training the next lot of people within the country so that they can take this therapy forward in whatever institutions they get to be employed in subsequently. And for that end, we are now thinking of forming a cancer immunotherapy network. It's at an advanced stage of design and proposal. We are hopefully getting a grant from the government for this. And in this, we will be taking the field of cell therapy forward together. This will include design and development of CAR-Ts in IIT Bombay, and which does not involve genetic modification. A lot of that we will be doing in TMC itself. And the translation work we'll do together. Clinical trials can be begun with TMC or leading multicenter trials, or IITB is also going to be able to open directly for some of the products trials in other centers. And of course, with all this, we are hoping to become an education and training hub for cellular therapies so that people don't have to go abroad to learn all these expensive things, and they can do it right over here and take the field forward, because there's so much more to do. We are just 2 trials, and the world has got 1,007 trials ongoing on this. So there's a lot to catch up on. With that, I will stop. I have a lot of people to acknowledge. It's a long list, but I will leave you with this slide, and I'm happy to take any questions.
Thank you, Dr. Gaurav, for taking us through the long journey. You have achieved what very few people achieve, and thanks for putting it across to all of us. Millions must have congratulated you, and I just one more addition to that long list. Congratulate you for your great success story. Questions?
Thank you, sir, for the kind words. Thank you very much.
Questions, please.
Gaurav, I have one question, sir, with your permission. Can I ask a question, Gaurav?
So, please, sir.
So, like, we're all very proud of you, as Dr. Agarwal said, and we are, praying for your success. My question to you is, why are there so few trials in India when you compare to, say, for example, China? Why do not more centers start trials with CAR-T cells in our country?
Sir, I am sure that shortly we are going to see many trials opening up in the country. There are 2 things which you can do. One is that the difficult part is having your own IND. So to develop your own IND requires ground up research, for which people need the requisite technical skills, experience, and knowledge, and need to be innovators in that field. We were lucky that we had a person like that in our backyard, Dr. Rahul Pulwar, a great scientist. But the fact of the matter is that there is a paucity of scientists with that capability in our country. There are many who are abroad right now and working in the top institutions, but they're all over there in those institutions. Rahul chose to leave a career and Harvard and a career in a private company and came back to India. And probably if he hadn't done that 10 years ago, we would not have been here today. But so that is when it comes to having your own IND. But then that, to me, that was the biggest thing, that we needed to have our own IND, because that gives us the capability. Without the IND, the options are then to tie up with the people who are developing INDs abroad. But for that, there are hurdles in that for products which are developed abroad, our laws do not permit phase 1 trials on Indian soil for products which are developed abroad. You got to complete the first one in your own country and then come to India. You need to, so that's a basic hurdle. So you need products which are working and at least reaching phase 2, phase 3 stage. And those trials can definitely be conducted in India, but you don't have ownership over them. So that's the problem. So you need to get into partnerships. And that's what I think a lot of groups are doing. And I am quite sure that the field is going to come really wide open in 21-22. And you're going to see multiple trials opening up, and the field is going to hot up a lot. And we are so glad that's happening, because we got thousands of patients to treat. Even now, the number of patients which we are having to turn back on the trial is heartbreaking, getting calls from everywhere. But we've got only permission for 6 patients as a start, for ALL and 10 for DLBCL. There's so much to do. I'm very excited about what's happening. So I think there's going to be lots more coming, sir.
Purna, you are not. Anyone else has a question? Go ahead, Purna.
Can you hear me now?
Yes.
So my question is, what will be the, once you are done with the clinical trial and it is in the clinical practice, what will be the turnaround time? Like if I have a child with a relapse now, and child is ready to go for the CAR-T cell, parents are ready, what will be the turnaround time like? Starting from the diagnosis of relapse to giving the CAR-T cells, TAT, because that gives you the time, realistically, it will give you the timeline as to how we can manage these children.
So there are 2-3 things here, ma'am. You need to do a collection. You need to manufacture the T cells. and then you need to infuse them and monitor the patient after that. So these being the three biggest phases. Now each one of them has its complexities and will vary with each child. To do the collection, you need a fair number of lymphocytes in the peripheral blood. We can do with the ALC count, absolute lymphocyte count of as low as 600. But a child who's relapsed or refractory or just coming out of chemo may not even have that much. So you need to manage the patient till you reach a point, optimal time for collection. So that can sometimes take a few weeks, and sometimes it can be done very rapidly, done immediately. The patient may be having a good lymphocyte count, and you can go ahead and do it. So that can vary, but that's the first challenge, collection. Then comes manufacturing. So current manufacturing, it takes about 5 to 6 days, 7 days maximum to get the required number of cells ready. But after that, we have to do the quality control tests and the release criteria. That adds another 2 to 3 days to the process, because culture exists, especially you've got to wait 2 days, 3 days for the culture at least to see that it's negative before you give it. So that adds 2 to 3 days to that. So you can say roughly 10 days to 14 days is the manufacturing time. And so if you add the other part that comes is that you may have done the collection, but but in these 10 days, the child may, maybe in a clinical condition where they maybe deteriorate rapidly, because we are not, unlike transplant, we are not taking patients who are in remission. You're taking patients who have got flank disease. So even in those 10 to 13 days between the collection and the infusion, they may progress. So one has to manage the child in the between. And sometimes that management can lead to complications, and it can create further hurdles. So I think, if you, best case scenario, I would say child is ready for, getting the CAR-T, you refer, 3 days later you collect, and 10 days later you infuse. That would be the best case scenario. But it will be very difficult to match that in actually patients who are needing it. I would give a month.
Thank you. Other questions and comments? Okay, then thank you, Gaurav. And Professor Prakash,
Yes, sir.
thank you very much for involving me in this wonderful meeting. And it was a great honor. And thank you for organizing this.
It is our privilege to have Dr. Agarwal chairing as hematology session in TYAcan. So thank you so much for that.
Thank you, dear. Over to you.
Hello. Can we have Dilip Aleria? आप अपनी बात कह सकते हैं.
हाँ सर, मेरा नाम दिलीप अलेरिया है. मुझे एमएल हुआ था लुपीमिया. मुझे 2015 में ये पहली बार पता चला, जब जांच वगैरह करवाई, खांसी चल रही थी, ब्लड भी, खांसी में ब्लड आने लगा. तो फर्स्ट बार जब जांच करे तब पता चला कि मुझे यह बीमारी है. तब अनिल सिंघवी सर के पास मैंने ट्रीटमेंट लिया, जिसके बाद 2017 में वापस यही बीमारी हुई. जिसके बाद हम टाटा मेमोरियल गए, वहाँ पे हमको अपॉइंटमेंट नहीं मिला, 9 महीने की वेटिंग बता रही थी. जिसके बाद हम सर के पास आए, अरविंदो में चितालकर साहब के साथ. उन्होंने मेरा ट्रीटमेंट किया, मुझे कीमोथेरेपी दी. जिसके बाद उन्हें बोला कि आपका ट्रांसप्लांट किया जाएगा. फिर ट्रांसप्लांट के लिए डोनर मेरे भाई का सैंपल लिया गया, तो उनका मिला नहीं, इसलिए फिर मेरे कजन का लिया गया, उनका मिला. और उसके बाद मेरा 21 जून 2017 में वापस ट्रांसप्लांट हुआ, और जिसका ट्रीटमेंट चला. और आज मैं ठीक हूँ, अच्छे से अपना काम कर रहा हूँ, और किसी भी प्रकार की कोई प्रॉब्लम नहीं है. समय समय पे मैं सर के पास अपने चेकअप के लिए जाता हूँ. कुछ भी छोटी मोटी समस्या होती है तो सर से ट्रीटमेंट लेता हूँ. थैंक यू.
बहुत बहुत धन्यवाद. थैंक यू.